Hi guys, I'm going to review renal and the urinary system with you today. I know you had a lecture recently on this. This is just going to be a quick review. Again, our renal system, kidneys, ureter, bladder, urethra, shorter in females. Okay, the little guys that sit on top of the kidney are your adrenal glands. Okay, for hormone production. Okay, so how do our kidneys work? What are they responsible for doing? Well, that's a very intricate question because they do a lot. Okay, first thing is that they filter our blood. What are they filtering out? They're filtering out urea, creatinine, ammonia, okay, and other toxic and harmful substances. Okay, fluid and electrolyte balance, sodium, potassium, calcium, chloride, all of those things. Okay, if our body is dehydrated, it's going to hold on to that sodium, okay, and causing more water absorption from our bloodstream. Okay, it is also responsible for erythropoietin production. Anybody remember what that means? That is a hormone that is released by the kidneys that tells the bone marrow to make more red blood cells. Okay, kidney disease can cause a decrease of erythropoietin that leads to what? If you don't have enough red blood cells, it is called anemia. Anemia of chronic disease. Star. Okay, that is due to decreased erythropoietin production. Renin. I know, hopefully it wasn't too deep yesterday on the renin side of it, but renin, angiotensin, aldosterone, those are all hormones, if you will, that the kidneys secrete. Okay, we call it a RAS system because renin triggers angiotensin, angiotensin triggers angiotensin 2, and then also aldosterone causes sodium and water retention. All of these happen when our blood pressure is low and the body is trying to compensate. So the kidneys are doing their part to help increase our blood volume, to increase our blood pressure so we don't die. Okay, so we'll get into that. When they're sensing low blood volume, they start secreting these things. Okay, and that's how some of our medications work, by blocking these things to lower blood pressure. Okay, kidneys are also responsible for vitamin D conversion to what we call calcitriol, okay, which is the active form. Okay, that way we can absorb it and through our intestines and then increase our bone density. Okay, also important, if our kidneys are failing, we're not converting vitamin D over. Therefore, our bones are brittle. Okay, you can have something like osteoporosis, osteodystrophy. Okay, so those patients will usually have to supplement their vitamin D because the kidney is unable to process and convert it like it should. Okay, all right. Kidney also works in acid-base balance. What's a normal pH? 7.35 to 7.45. Okay, the kidneys work to help prevent acidity. Okay, when the kidneys are not working, we end up in something called a metabolic acidosis. Okay, some ways that the kidneys work to prevent that is that they will secrete what we call hydrogen ions. Okay, and that is to help lower the acidity level, or they can reabsorb our bicarb, which is also known as HCO3. Okay, and that will help to neutralize acids. Okay, if they're not working, we can end up with a metabolic acidosis. Okay, and that is very common in renal patients. Okay, so those are some of the big things that we need to know, and you need to be able to connect those dots. That the kidney is responsible for fluid and electrolyte balance. Okay, for blood pressure control, for vitamin D conversion, for erythropoietin production. Okay, and removing waste. If we don't have a functioning kidney and our glomerular filtration rate, GFR, falls too low and we go into kidney failure, which is considered less than 15%, you have two options: dialysis or death. Okay, so that's the basic rundown. Okay, now we're going to talk about some more pathophysiology. Okay, so what are some things that can cause the kidneys not to function as well? Well, you have a couple different. You can have what we call a pre-renal cause. pre meaning before, renal meaning kidney, so before the kidney, okay? Anything that happens before you get to the kidney, okay? One of the most common can be hypovolemia, which means what? Low blood volume, okay? So low blood volume, that could be from hemorrhage, from a mass casualty trauma, okay? Where you're bleeding out. You've got your leg chopped off. So you're bleeding out, you have no blood volume, okay? That is a pre-renal cause, okay? Dehydration, severe nausea, vomiting, diarrhea, or just being in NPO status, failure to thrive, not eating, not drinking. Severe dehydration also equals hypovolemia. Hypovolemia equals less blood flow to the kidneys. They're going to do all those things that I said to compensate prior, okay? Another thing could be you're not getting enough blood volume to your kidneys because your heart is not pumping effectively. If your heart is not giving you enough of that stroke volume that I know you guys have learned about, okay? If it's not pumping out enough volume to perfuse the body, then you're not going to have enough fluid and blood volume to the kidneys, okay? All right, other pre-renals could be a tumor, an obstruction, pre-renal, okay? All right, so that's everything pre. So you need to make sure you know that. Dehydration, hypovolemia, mass hemorrhage, okay? Anything before the kidney, all right? Intrarenal or renal causes per se is the most severe because the actual nephron of the kidney is not functioning well, okay? One of the main things can be infection, which we call glomerulonephritis. If you remember the little inside of the kidney, okay, let me see if I have a picture up here. When you cut a piece and zoom in, you have your nephron, okay? Your nephron is the filtration area, okay? Let's see if we can flip around real quick. I'll just flip the camera. The nephron area right there, the little yellow guys, okay? If they're not functioning appropriately, or if they get infected, that is called glomerulonephritis. The glomerulus is inside of the nephron, and then if that is infected, then you can have glomerulonephritis, okay? Lupus is an autoimmune disease that can also affect the kidneys, okay? Autoimmune disease. Again, certain things can be nephrotoxic, meaning they're toxic to the kidneys, okay? Such as antibiotics or CT, CAT scan dye. Okay, that's the contrast, CT contrast. It's nephrotoxic. So if a patient already has poor kidneys and we give them too much of that, then it can make them stop working even more. Okay. Again, another thing, especially for you athletes, if you go run a marathon or you played football in the heat in the summer, you didn't have enough hydration, your body's going to start breaking down the muscle, okay, the myoglobin, okay. Our kidneys cannot process the myoglobin molecule because it's so large, okay? So then you start to have the tissue releases the myoglobin, which damages the kidney, and we call that rhabdomyolysis, okay? It looks like you have blood in your urine, but it's actually the myoglobin that the kidney cannot filter, okay, being secreted. So it's muscle damage that can lead to kidney damage, okay? All right. How do we fix a lot of these? Well, it depends on the cause, okay? Third cause of renal dysfunction is post-renal, okay? Post-renal. Think about this, anything that backs up, okay? Backs you up, okay? A lot of times these are gonna be a kidney stone, okay? A tumor, BPH, benign prostatic hypertrophy, okay? Or hyperplasia. Or damage to the bladder and it's not working, and then you have back up, the fluid just backs up to the kidney and further, okay? Causes damage, okay? So anything that blocks and then backs up is gonna be a post-renal, okay? So after the kidney, all right? The pre-renal, the intrarenal determines how we fix it, okay? If it's hypovolemia, we have to give them fluids. If it's due to infection, we have to treat the infection. And if it's CT dye, then we have to hydrate them and hope for the best in that aspect. So when we have damage to the actual kidney, you can have two types. You can have acute renal injury or chronic kidney disease, okay? Usually for the acute kidney disease, acute kidney injury, that is reversible. That's the biggest thing to know, is that it's reversible. Usually the definition of that is that your GFR will decrease by about 50%, but it's considered reversible with fluids, with hydration, treating the infection, okay? For your chronic kidney disease, that's a progressive, slow decline of the GFR. This could be due to hypertension, which equals poor blood flow to the kidneys over time. Could be due to diabetes, exposing them to sugar, which is not good for the kidney as well, over time. So a lot of people on dialysis, if you ask them what caused you to be on dialysis, it's hypertension, diabetes, lupus are some of the top 3 that you'll hear about. Okay. Also polycystic kidney disease, that autoimmune, autosomal recessive polycystic kidney disease, that can also cause that. Okay. For chronic kidney disease, just to throw that out there, usually you'll have to track your GFR, and then 3 months later, check and track your GFR to see if it's still declining. So you need 2 documented levels, 3 months apart, before you can classify as stage 1, 2, 3, 4, 5 in kidney disease, okay? I know you guys probably had a lecture over the kidney disease, okay? Stage 1, if you think about it like 100% or higher, okay? Most of us, normal healthy human beings, are gonna have a GFR that's 100 or greater than 100% because we're doing great, we're A-okay. We can drop a little bit here or there, say you're not hydrating enough during nursing school or your first RN job, you have your labs drawn and your GFR comes back at 90, okay? If you are, less than 100, but slightly around the 90 level, we kind of can call that stage 1. We just say, hey, hydrate more, okay? Stage 2 is 60 to 89 for that GFR, glomerular filtration rate. That's the amount that the kidneys are filtrating, okay, per minute. Stage 3 is 30 to 59. Stage 4 is 15 to 29. And stage 5, which you guys do need to know this, is less than 15%, which equals death or dialysis. We have to figure out something, okay? When your GFR goes down, a lot of times your creatinine will go up. They're inversely related, okay? Elevated creatinine can be a sign of dehydration or kidney disease, okay? All right, we talked about that. All right, the best test, I would say, if you're trying to determine a patient's kidney status, is called a 24-hour urine, okay? 24-hour urine collection is a creatinine clearance test, okay? That will show us their potassium, their phosphorus, their magnesium, okay? Their ability to produce the erythropoietin, okay? You may see blood in their urine. You may see protein in their urine. All of those things can be seen in that 24-hour urine jug. It's a big orange jug that they're given, and they have to pee in it, put it on ice, take it back to the doctor, and it's analyzed in the lab, okay? Okay, so a couple things. How do we treat this chronic kidney disease, and how can patients potentially die from it? Well, if the GFR is too low, okay, and they get put on dialysis, then they're at risk of having a certain electrolyte build up in their system. Because our job during dialysis is to remove that excess toxins and electrolytes, i.e. potassium, okay, which can be cardiotoxic and cause us to go into arrhythmias, okay? So if they miss dialysis, that potassium is going to build up in their system, okay? What have we learned about potassium is it really affects the heart, like I just said, and then you can have fatal arrhythmias, okay? Renal patients have problems with their fluid because if the kidneys aren't working, it's not doing well with that renin, aldosterone, antidiuretic hormone. It's not doing what its job maintaining that fluid balance, okay? A lot of dialysis patients will pee a lot less, if any. Some dialysis patients do not make any urine, okay? So they need diuretics. If they're still making a little bit of urine, we can give them diuretics to help get off excess fluid, okay? Because when they go to dialysis, we're removing fluid, but we're also removing all those toxins, like I said, and the potassium, okay? Some things that we'll get into more in adult 1 also is the treatment for adult 1 and farm, the treatment for hyperkalemia in chronic kidney disease. And we'll talk about that. I do not believe you guys got into that as much in patho. All right, so let's see. Again, they need to monitor their daily weights because if they're gaining multiple pounds in a 24-hour period, they're probably having fluid retention. These patients also need to avoid what we call NSAIDs, which you guys will learn more about in pharm. Those are non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen, Toradol, because those are also rough on the kidneys. Contrast diet, like we already talked about, and then magnesium supplements such as Mylanta and Maalox. Okay, that is the review that I can give you is in a quick, less than 20-minute video for acute kidney injury and chronic kidney disease. Okay, remember, a lot of the top 3 causes are uncontrolled diabetes, uncontrolled hypertension, and autoimmune disease, such as lupus, okay, or the polycystic kidney disease.